at Stanford University.
Thank you. Thank you very much. It's a pleasure to be here. It's great to see you all back. I hope you're enjoying your weekend and having fun on a Saturday afternoon. I actually count talking about healthcare reform as fun, so I love being here doing this kind of stuff. Happy to have an hour to spend with you all. So they asked me what I wanted to talk about. I said we'll call it grand challenges and grand opportunities. Where's the healthcare system headed? Because I figured then we could talk about whatever we wanted. So that's good. So I thought originally that maybe we'd talk about some basic background stuff. There's some very interesting data and underlying theories that drive how people think about the healthcare system, how we think about whether we're efficient relative to other countries or not, how we think about where we ought to go. Fascinating stuff, but how can we have a title like Grand Challenges and Grand Opportunities and not talk about what's been going on in Congress lately? So that's what I figured I would do. I don't know if I stand in different places if this thing works better or worse, but I'll stand over here and that'll work, and I'll try over there in a little while. So I figured what I would do is probably the best thing to talk about is spend a little while setting up the context for what we've been doing in Congress lately. We're talking about healthcare reform, you all noticed. And then I'll try to do some of that, get to the point of just a brief outline of what came through the Baucus Committee, the Senate Finance Committee, in the last couple weeks. Try not to get into too much detail. We could spend a long time talking about what's in the Baucus bill. But then try to leave lots of time for questions. I figure it's probably more interesting for us to talk about the things that you're interested in than for me to talk the whole hour. So I'll try to do about half an hour, 35 minutes of sort of background setup, and then we can do questions and answers, things that you're interested in about the US, other countries, kind of the stuff that I'm paying attention to lately goes all over the map, and happy to talk about whatever we go from there. So hopefully that'll work. So we've been doing healthcare reform lately, and we're doing a particular version of healthcare reform lately, and we're doing it for some fairly specific reasons that we can trace back and that come out of the historical development of public opinion and the politics of healthcare reform in the US, and that come out of the history of attempts to change the healthcare system in the US going back to Clinton and to the Nixon administration. So looking at two threads of where the country is and what the ideas are will help us see why we're doing what we're doing, and then we can talk about exactly what it is we're doing. So the first part of that is public opinion, the politics of healthcare reform, the ways you can work with the government to start to change something. And in order to get a handle on what's going on there, we need a little public opinion polling. So here's the first public opinion poll question we have to deal with today. I'll ask your opinion in just a second. Actual poll question asked frequently of people when they get bothered on the telephone in the middle of their dinner. Now, which of the following best describes your opinion about the US healthcare system? A, on the whole, the healthcare system works pretty well, and only minor changes are needed to make it work better. B, there are some good things about our healthcare system, but fundamental changes are needed to make it work better. C, our healthcare system has so much wrong with it that we need to completely rebuild it. All right, think about it. Complicated question, lots of options. A, on the whole, pretty good. Okay. B, fundamental changes. Ooh. All right, C, anybody for total? You guys are, oh man, see, it's all about statistics. You have a large enough sample, you mirror the American population. Here's American population data. This exact poll question has been asked every year, at least back to 1982. So we've got 30 years almost of opinion poll data on this question. And actually a similar question goes back to 1970, and it's almost the same if you track it all the way back. So this is a graph of 1982 to 2008. I have the 2009 data, but my daughter had a soccer game and my son has a science experience, all this stuff. So no 2009 data, but it's the same. The trend is the same. In the red on the top, answer B, some good but fundamental changes are needed. Since 1982, 50% of the American population has said fundamental changes are needed. You all said a little more than 50%, I think, but you all were kind of on par with that one. Green line in the middle, completely rebuild it. Since 1982, about a third of the US population has said completely rebuild. If you sum up fundamental changes and completely rebuild since 1982, 80% of the American population has said we got to do something about our healthcare system. Blue line in the bottom works pretty well, has always been 15 to 20%. It's been coming down a little bit lately. And then the politics of the moment will make it go up or down every week. Now in the last few weeks, it goes up or down a little bit, depending on what people are thinking about. Huge support for changes in the US healthcare system going back 30 years, going back 40 years. I bet you could even get it into the mid-60s, but they just didn't have the question then. The challenge and the politics and the kind of issue that's confronted everybody, why haven't we done anything? It's because when you start to dig below this, and I didn't bring the slides, they take too much time to go through. When you start to dig below this, what you'll find is everybody wants healthcare reform and everybody wants something different. Everybody has their own favorite version of healthcare reform. So you can put out a question that says, do you support this, 10 or 15 different things? Everybody will say, oh yeah, it's probably fine. If you ask them their favorite, it'll be split exactly across all of those different things. So trying to get this kind of idea of health reform in general focused into something specific has been really hard for the healthcare system, for the folks who drive healthcare. And one of the remarkable things about what's going on in Washington now is they've actually started to navigate this. They've been able to sort of work through some of the differing ideas and get something that enough people are able to support that they can make some progress. We'll see that happening in a little bit. That's thing one. We got a lot of support for healthcare reform, but we've had a hard time getting people to coalesce around the ideas. Polling question number 2, part 1. Thinking about the country as a whole, are you generally satisfied or dissatisfied with the quality of healthcare in the country? Okay, we got only, so this would be like you get a scale if you were actually answering the question, but I'm going to go very satisfied, somewhat dissatisfied, and very dissatisfied. You get 4 choices. So how about very satisfied? Got some very satisfied. Okay, how about somewhat satisfied? A little satisfied. Good. Okay, now switch to the other side. A little dissatisfied. Yeah, okay, now very dissatisfied. All right. Okay, I've got more on the satisfied side than on the dissatisfied side. That's the thing I'm going to pay attention to. Now, what about the healthcare you receive? Are you generally satisfied or dissatisfied with the quality of healthcare that you receive? Very satisfied? All right, I don't even have to do any more. That's like it. Anybody else? Dissatisfied? A few people. I started on the dissatisfied. So, right. We'll go around. This is just like the country. Thinking about the country as a whole on the top, polling data from the last couple weeks, are you very satisfied? 11% somewhat satisfied, 27%. About a third, 40% of the country says that they're satisfied with the quality of healthcare in the whole country, but themselves, coming up on 80. Right? 80% say theirs is fine. If you ask about cost, same thing. Are you satisfied with costs in this country? No way, it's terrible. What about your situation? Okay, fine. Not really a problem. I can handle it. And this is the second thing then that drives where we are today, and it drives the debate. It has driven the failure of healthcare reform in the past. We have 60, 70% of the population that has healthcare coverage right now. They've got it from their employer. They've had it for a while. They're pretty satisfied with it. Any kind of healthcare reform that we're talking about that would start to change that erodes a base of support of people for the current system and starts to look like something that they don't like. Meanwhile, everybody says, well, we got big problems. We ought to do something. And so trying to bridge this divide between I want to do something in general, but not something that takes away what I've got that I like, has been an Achilles heel for healthcare reform. And a remarkable thing about what's going on in Washington now is the ability to start to navigate this. And we'll see that happen in a little while, too. The kind of political reality here is driving what they can do and why they're doing it. And it has to do with navigating how people think about the whole system versus their own. Last poll question. How much of the time can you trust the government in Washington to do what is right? You get 3 choices if you're on the phone, just about always, most of the time, or some of the time. On any given poll, 5 to 10% of the American public will volunteer never. So you get to, we'll give you D, you can have never. If you want never, because people just make it up themselves anyway. So 7%, 8% of the time that'll happen anytime you phone people up. Okay, just about always. Didn't even have to ask. Most of the time, there you go. Some of the time. Okay, now you get D, never. A few people want to go for never. All right, there you go. This is a really hard one. This is the remaining hard one for the folks in Washington who are trying to do healthcare reform right now, navigating this one. This exact polling question got asked for the first time by CBS News in 1958. Here's 1958, here's 2009. 1958, when they asked this question, 75% of the American public trusted the government to do the right thing just about always or most of the time. It hits the all-time high in 1961 at 78%. And then it starts to fall. By the mid-60s, it's 70%. I direct your attention actually to the mid-1960s, which is the last time the US did any significant reform of the healthcare system with the enactment of the Medicare program. 70% of the American public trusted the government to do the right thing just about always or most of the time. And then what happened? Hard to say exactly. The 60s happened. Watergate happened in 1973. Right there, you can kind of notice that one. 70s didn't help. 80s look up a little bit. We like Reagan, I guess. That was a good thing. Then Clinton era comes along, not much. You see the big bump in 2001. That's 2001 and the World Trade Center bombings. Actually, they were in the field with this question on September 12, 2001. It was 80%. So it went way up, and then it quickly kind of regressed to the mean. So you see the bump. and then it declines. The lowest all-time level recorded in history for this question, 16%, right before the election last year. 16% of the public trusted the government to do the right thing just about always, or most of the time. It's bounced around since then. So I put on kind of the monthlies for the last month up there. You see it kind of banging around 20%. If you want to do major healthcare reform that involves the government, you got a big problem. And so at the same time, if you want to do major healthcare reform that addresses some of the fundamental failings of a private insurance system, which can do some nice things but also faces some real challenges, you have to use the government. And so figuring out how you're going to do that in a way that makes sense to enough of the American public to buy it, in a way that looks like it's going to be efficient, and handles the fact that 16% or maybe 20% now of the public believes that the government can do the right thing, very hard problem. They're trying to navigate this. What they're doing in Washington is hugely driven by the realities of the perception of the government in America. And in some ways, this is the one that they haven't quite figured out yet. Public option, not public option, co-ops, Susan Collins, all these various people's ideas are still floating around this because they haven't quite figured this one out. But this is the one, this is also driving what they're doing. All right, so we got to deal with the politics. We're partly where we are because of the politics. We want health reform. We've got to try to get something that everybody can coalesce around. We've got to do that in a way that respects the fact that a lot of people are happy. Enough people at least are happy with what they've got. Some people are less happy now than there were before, so there's been some trends, which is kind of interesting. But we've got to finesse that. And we've got to do it in a way that at least looks like it's not using the government a lot or somehow convinces people that that's going to be OK. That's going to create the big problem, the big challenge of this that's going to lead to where Obama is. Other thing that leads to where Obama is right now, or the Congress is right now, is the history of health reform efforts in America. If you go back, you can go back to 1910 almost, 1908 actually, and find some health reform activity. People have been doing it. There's a little bit of a cyclical theory. It looks like about every 20 years we try health reform. There's a 1910 reform. There was some stuff that went on in the 1930s. FDR had some proposals about health reform. There was something that went on with the Truman-Dewey election that happened right around 1950. So kind of every 20 or 30 years. Then around 1965-70, there was a big health reform debate. And I'll start with that one because we don't have all day to go through the history of all this stuff. And because this is the first debate, the Kennedy-Nixon and the single-payer debate of 1970 is the first of what probably could be termed the modern era of healthcare reform discussions. They introduce the kinds of proposals that we're still talking about today. They really set the stage in some ways for the debate that we're having today. And they did it in the context of a healthcare system that's not so different than what we have today and facing problems that are not so different. In fact, if you go read the literature from 1970, it sounds exactly like the literature from today. Just change all the numbers. We got a lot of uninsured people. We got a lot of high costs. We're worried about quality. Incentives aren't right. You just say, well, everything costs 20 times as much now, and you can just take all the old editorials and republish them. Maybe that's what they're actually doing. Don't know. So what happened in 1970? Well, Ted Kennedy then, was a new senator, proposed what we call a single-payer. You probably all have tracked this down, a single-payer health reform for the US healthcare system. One of his signature kind of themes was health reform all through his career, and so he got started very early as a new senator. He proposed single-payer system. Single-payer system would have collected taxes from everybody, use the taxes to pay for healthcare for everybody. In private insurance companies, basically out of the picture. So there's a single payer. There's one group that gets all the money. They pay all the doctors. They pay all the hospitals. Everybody's kind of in no matter what happens. Looks a lot like the British healthcare system, something like the Canadian healthcare system. He proposed this in 1970 and put on the table by doing that single payer as an option in the US. And it's sort of been an option floating around, not really an option this year because of 16% of the public believing that the government can do the right thing just about always or most of the time. But he kind of put it out there and it stakes out a point in the debate. Nixon responded, and Nixon responds with the other thing that has, or one of the other things that's been part of the debate, and that is an employer mandate, what we call an employer mandate. Employer mandate is a law that says every employer has to offer health insurance to the people who work for them, to their workers. So this seems like a good idea. We've got a lot of people getting insurance from their employer, but some people don't get insurance from their employer. So if we only had a law that all the insurance companies would have to do this, then we'd have more people get coverage from their employers. That would take care of some of the problems of the uninsured. That was what was driving Kennedy to offer the single payer. So Nixon responds with employer mandate and also puts on the table one of the big options that floats around in every discussion since then. Single payer and employer mandate are out there. Little bits of employer mandate are still there in the Obama and in the congressional proposals now. This all got started in the 1970s. And without going through the debate in a really big way, what happened in the end was the clash of the politics that we just talked about. What happened? Well, there's a lot of people who've got some build-up incentives to keep the system the way they were in 1970, just like they do right now. They didn't want to get forced into some sort of single-payer plan, so that kind of eroded support for the left. The employers and other people didn't want the government getting involved in their activities, so eroded support for the right. They just all decided to go home and do something else at the end of the day, which is kind of what happened. At the end, there was no big denouement in this one. They fought for a little while and they decided to quit. So they just kind of quit and it stopped. But it sets up these two big options, and it sets it up in the context of the politics. So you see the single payer and the employer mandate come back around. The next time you see them come back around is in the early 1990s. Bill Clinton ran for office, and he decided he would run on a couple things, the domestic economy and on healthcare reform as a couple of his big issues that he wanted to work on. So he picks up the Nixon proposal. He's a Democrat, surprisingly, but picks up the Nixon proposal for an employer mandate. The Clinton health reform proposal is essentially an employer mandate, a big law that would make all the employers try to have coverage for all their employees, and he wraps around it a bunch of other stuff that he thinks would try to make it easier for them to do that. But basically, it's an employer mandate proposal, just like what the Nixon kind of core structure was going to be. He does that, gets elected, puts that out in Congress, and then kind of also gets slammed along the lines of the same politics and the same kinds of issues that were coming along with the Kennedy debate. So the insurance industry shows up and says, we don't want you to have a lot of changes in the structure because we're happy with things the way they are now. Don't mess with our business. Individuals started watching ads on television that said, oh, you're going to get forced to change your health insurance plan. And they said, but we're happy now. We like what we have and we don't want to have to change the plans. And it could be easily portrayed as a big government kind of solution, which it was. If you look at the political cartoons and things of the time, same politics kind of derailed this. But sort of continued the idea of the employer mandate. Come out of the early 1990s, coming out of this debate with a failed, went to Congress, failed, didn't get passed, people started to despair a little bit because they started to say, well, thinking about what we can think about at the time, the breadth of options that are available to us looks like single payer and employer mandate. And both of them have now clashed with the politics of the country. We can't actually get those passed. We need a new idea. So that's actually kind of what sets us up for where we are now, because the Obama plan, the Congress plan is kind of a new idea in this direction. And it comes because we failed with our two earlier versions of health reform, and they had to come up with something new. What did they come up with? Well, they look in the middle, sort of in the early 2000s, Massachusetts started doing something. They started doing something a little bit different to try to get their population covered. What did Massachusetts do? They came up with a different kind of law, a different kind of reform. At the core of it is what they call the individual mandate. So it's option 3, need the third option, and they've kind of found it in Massachusetts. What did Massachusetts do? Well, instead of single payer, instead of an employer mandate, they decided they were going to pass a law that every individual had to have coverage. So if you live in Massachusetts, basically it's against the law if you don't have health insurance coverage, if you didn't get yourself an exemption, which they'll grant for various reasons if you have a good reason. Get a note from your parents and you're okay. So they have the individual mandate idea kind of created in Massachusetts. It looks like something that you can actually use, like there's an actual example of it. It's got some problems, and if you want to talk about that later, we can talk about the challenges Massachusetts has found with their health reform. But it looks like a new kind of a model. And it doesn't look discredited like a model that the Clintons tried and failed. And it doesn't look like a big government model like the single payer model. So what's Obama going to do when he shows up for running for office? He's looking for a model. He grabs the model. And so he is positioned where he is with an individual mandate. That's the core of it. He's going to pass a law. I'll talk in a second about what he's going to try to do. Yeah, we have time for that. And he's going to use an individual mandate to try to do this. A lot of people say, well, why didn't he do single payer? He didn't do single payer because of the politics and because of the history of single payer. Why didn't he do some more with the employers? He does actually do some stuff with the employers because there's a history with the employers that didn't really work out for the Clintons because there's some issues with the politics associated with it. This looks like maybe a new way to think about it, and so we're kind of where we are now because people have been hunting around for a way to sort of navigate the politics and do it in a way that doesn't get stuck in the same stuff that healthcare reform has been stuck in before. Now, it still might, and there's a bunch of things that you might not like about the individual mandate. There's certainly things that we can talk about there and things that I get worried about. But we're here talking about an individual mandate for some very specific reasons that come out of the history and the structure. So what are we talking about? Now you got to tell me if I'm getting too detailed. Oh, we're talking about fixing two challenges. Yeah, this is actually worth talking about. we're talking about fixing, let me sort of structure this part around two challenges that we're trying to deal with. If you think about what's wrong with the US healthcare system, you could probably make a long list. Might be a fun list and interesting to do if we had a big, long thing to write up, but we could probably separate most of it into two different camps. One set of issues with the healthcare system is the fact that we got a lot of people who don't have health insurance coverage. This is the government official statistics about how many people don't have health insurance coverage, something like 45 million. We can have long discussions about how many of those are in different circumstances because there's some interesting stuff about how many people are actually uninsured for very long and whether it makes much difference. But some of those people, 40 million, some of the 40 million are uninsured in ways that we really get worried about. And we want to have maybe a public policy solution to start to deal with them. So part of the issue that Obama is dealing with is trying to get more people covered. That's where all the attention really goes these days. The other piece is that costs are going up like crazy. This is just a graph of the US healthcare cost as a percent of the gross domestic product, which has been growing up persistently since 1960, headed for 20% in the pretty near future. And people who have to get their wallet out to pay for this are feeling their wallet get a little thinner and not so sure where they're going to get the money in a little while. So the other problem with the healthcare system, separate from, not entirely unrelated to, but separate from the problem of how many people have insurance coverage, whether that coverage is stable, whether it's going to be there for you, is that healthcare costs are going up. They have basically punted on this one. Right? They've gone after coverage in what they're doing, and they've done some things to maybe start to address the cost, but they're not really going after addressing the cost. We can talk about this also a little bit more or less, depending on your interest. But the cost is the really hard part. The coverage is hard enough, but they're not really going after the cost. So let's talk about what they're doing to try and expand the coverage. I'm going to talk about what they're doing in a very specific way, because else we'd just be swimming in all the details. There are right now 5 different bills in the Congress. I don't know if you've been tracking this. There are 3 bills in the House of Representatives. They've done a pretty good job in the House of making sure all the bills are the same, but they're not exactly the same, and they're all like 1,000 pages or more, so hard to figure out the details. 3 bills in the House, 2 bills in the Senate that have made it through committee. One made it through the Health, Education, Labor, and Pensions Committee, and one made it through the Finance Committee. The HELP Committee used to be chaired by Ted Kennedy, so we call that the Kennedy bill, and the Finance Committee is chaired by Max Baucus, so people call that the Baucus bill. 2 different bills. Those are not the same. They're generally the same. They have an individual mandate in them. They have some other features that are the same, but they're not the same in the details. And so if you wanted to say what's going on in Congress these days, I just go, oh my God, what are we going to do? Because there's 5 different ones, and they're all a little bit different. So what I did is I got the Baucus stuff out. The Baucus is the most recent. It's gotten most of the coverage. It's probably a reasonable idea about where things are going, although even that's starting to get mixed up in the news in the last couple days. So Baucus bill. And then if you really want to get picky about it, not only are there 5 bills in committee, but the administration has bills that are not, has views that are not necessarily aligned. And Ron Wyden has some proposals, and there are Republican proposals. There are lots of other people who have views too. So what's going on in Congress is actually quite the mess if you want to start to figure it out. I'm going to talk about the Baucus bill, because that seems like a way to start to put things together. So this is the Baucus, I call it the Baucus chairman's mark, but it's actually the Baucus chairman's mark as passed through the committee. Last time I gave a talk with these slides was about 4 days ago. These are now badly out of date. So I'll tell you where things might have changed a little, or might be changing a little, but it's sort of hard to keep up with it. So what's going on in the Baucus bill? And in the Obama administration, and in all of the other bills. Actually, this part's pretty easy. The proposals all say there would be an individual mandate. There would be a new law. If you didn't have coverage in this country, you would get in trouble of some kind. They would either slap your wrist, or maybe they'd do something more serious. Most of the things that they would try to do involve making you pay some money. So there would be a penalty. If you don't have insurance, it might cost you $400, $700. It starts low and gets higher. Some people say then, well, that's sort of interesting because insurance cost me $5,000, so why don't I just pay the penalty and not buy it? And that's a very good question. So starting to kind of navigate how to make people do it and then actually enforce that if they don't is one of the sticking points in some of this legislation that has raised some interesting issues. So there's a penalty. It used to be up to $3,800 a year. You know, these are actually more than 4 days old. So now it's like up to $750 a year. That $3,800 has fallen in the last little while. So there is an individual mandate in all of these. There are going to be premium subsidies. You know, I should actually be able to edit these. So here's one way to think about what they're doing in Congress. They're going to pass a law that everybody has to have coverage, and then having told everyone they have to do it, they're going to do a whole list of things that are going to try and make it easier for people to comply with the law. right? So you said you have to have coverage, so now we're going to try and make your life easier, because if you don't have insurance, you're now really upset that you have to have it. So now we're going to try and help you out. One of the things that they're going to do to help you out is give you some money back on your taxes or some other place if you buy insurance. So if you're a lower income person, under 400% of the federal poverty limit, then you're going to be able to get some subsidy. Maybe you get $1,000 off or $1,500 off if you're close to that, the 400% of the federal poverty level. Maybe you get $5,000 or $6,000 or $7,000 off family policy if you're lower income than that. So they give people some extra money at the low end to try to make it more palatable for them to buy coverage. So that's one thing that they're trying to do. They're trying to do this thing called employer pay or play. That's a jargony thing. The idea is that you tell employers that if they don't offer some qualifying coverage to their workers, they have to pay a fee to the federal government. And if you're kind of in the jargon, you say pay or play, because it's really cool. And you say sort of you pay the fee, or you play by offering coverage to your workers. So they're going to do a little employer pay or play, vestige of the Clinton proposal, vestige of the Nixon proposal, still kind of coming through here because you're trying to make a list of things that make it easier, so they're trying to put that in. Only applies to larger firms, though, so small firms get away with it. If you're a small firm, they'll give you some tax credits. Maybe you're not offering coverage now, but if you offered, they would give you a tax credit to offer. So now maybe there's some reason for more small firms to do it. You start to expand the list of things that make it easier for people to start to buy. So premium subsidies, pay or play tax credits. They'd expand the Medicaid program. They'd expand the CHIP program. CHIP is the Children's Health Insurance Program, government program for kids. They'd expand that, or at least try to keep that the same without making it smaller. And then comes the big contentious one, public option and the co-ops. So one of the big proposals was try to build a new insurance program. We want to tell people they have to have coverage. We want to tell people that some of these things will help them. But then folks are still going to say, well, look, I'm sick, and I called up my insurance company to say I don't really want to give you a policy. It's going to be very expensive. Maybe we can pass some laws that would make it easier, fix some of that problem. But maybe what we ought to do is just create a brand new health insurance program run by the government so that everybody can get in. And it sort of maybe would have some public spirited ideas behind it. It would accept all comers. It would try to be fair in the premiums. We'd want to offer a public option like this as a way of making it easier for people to buy coverage. You could also spin this as a way of trying to discipline, if you will, the private insurance companies that are out there and try to say, well, here's somebody that will compete with you, and if you guys don't get efficient and don't reduce costs and don't start to get it together, then everybody will, of course, not want to buy yours. They'll buy this public option, and that would create some incentives. And so that's actually been quite the rub, because people in the insurance industry are worried about that. They're not so pleased with that idea. It's created a lot of debate. But the idea was to try and create a public option. Because this involves a government plan, and the public hates the government, and a lot of folks in Congress are worried about it also, there's been a lot of debate about whether they could do that. In the Baucus bill, what went through was not a public option plan. There was no new government plan that would put in there, but it would be put in. There was some money that would be given to some people in different states to set up insurance companies of their own that might try to look like a public option, that might try to do something more public spirited, and they called those co-ops. We can talk about co-ops more if you're interested in it, but that's what kind of made it through. There would be some money to try to help start some of these things. Probably wouldn't amount to a whole lot, but they would get some things through the public option in that vein, but not actually a public option. It's coming back, though. The big debate in the last week, if you've been following the news in detail, is the fact that there are a lot of people who are now trying to get it back in the Senate bills and back in the House bills, and there's going to be a lot of hoo-ha for the next couple weeks about whether the public option survives in these plans or not. And again, that's something we can get into a little bit more if you want to talk about that. Insurance market regulation, they would, along with all that stuff, they would say we want to put rules like no pre-existing condition exclusion on private insurance companies. So this is a long list of things. The idea, we're going to tell everybody they have to have coverage, and then we're going to try and make it easier, take away some of the barriers, and hopefully people would actually kind of look at it, try to get it in. Yeah, okay. I did the Baucus chairman's mark. Couple things that I would point out. Most of the other bills, I put similar up there very liberally. They're all different in various ways, but most of the other bills have some of the same characteristics. Premium subsidies are generally more generous in the other bills, so Baucus is the least generous. And the co-ops and the public option are replaced in most of them with something that looks like a Medicare-like plan, so a bigger public option that gets through. So they're trying to figure out right now which of those bills is going to govern in the end, and they're not sure yet how that's going to go. The folks in the House, Nancy Pelosi, and in the Senate, Harry Reid, are trying to figure that out, and they're trying to work it through. Some big differences in what would happen. The estimates of the Oh man, it got cut off on the bottom. All right, so I just have to tell you this because my slide says stuff that you can't see. So what would happen when we did this? Well, there are some things that people have tried to figure out. Would this actually cover very many folks? Would it actually cost too much money for us to be happy? And some of that's actually still kind of floating around. The estimates are, under the Baucus chairman's mark, that we would probably have about 6% uninsured in 10 years if they did this. Right now we have about 15% uninsured, so it would cut uninsurance by maybe half. Now this is based on the CBO estimates. The CBO estimates are done by very well-intentioned, very smart people with about 3 days to do this and a lot of jolt. So how well these things are actually, how accurate they are, whether we can depend on them, kind of a question. I don't doubt at all that they've got great models and they're working very hard. They've done a lot of work on this, but it's always a little tricky to make these kinds of forecasts 10 years out without all the data and without very much time to do it. So they forecast maybe we'd have about 6% uninsured. Get that down to maybe 3% uninsured under some of these other bills because the other bills have more generous subsidies, because maybe this Medicare-like plan would work, things like that. You get more bang, or you get more uninsured reduction under the other bills, but even the Baucus bill would go quite a ways. And then they try to figure out how much it would cost. And they do this sort of budgetary scoring thing. And that's maybe more detailed than we want to get into there too. But the estimates for both of these different versions, somewhere in the $850 billion range over 10 years. So $85 billion a year if you average it every year. Some of these things don't actually phase in for a couple years in order to keep that number lower, so that the average per year is higher once they get it phased in, $100 billion a year, something like that. They kind of come in around the same level. This one's still a little cheaper, but they've been fussing around with this one, these guys lately, to try to make them cheaper because they all want to have the cheapest one so they can win the race at the end of the day, and they're trying to kind of fuss with that. Let's not talk about financing because we'll talk about that in a second. So that's what they're going to do for coverage. Let me finish this up and leave enough time for questions by putting out there what I think is yet the unanswered question, and really what's going to be a big challenge for the U.S. healthcare system going forward and what we have to deal with. Another thing that we can talk about more. So the bills in Congress do something about coverage. They would expand coverage. They would make new options available. There are things to like about them. There are things to not like about them. But they head in the direction of expanding coverage. What's still out there, though, is increasing costs. Our healthcare costs go up every year. And they look like they're going to keep going up every year. What are we going to do about that? How do we think about that? These bills don't actually do that much, I'll claim. There are people in Congress who would hate me saying that. But I'll say that. They don't actually do that much to change what's going on with healthcare costs. What are the issues there? Well, if you look at why costs are going up, why the U.S., it's a slightly different question, but why the U.S. is higher than other countries, part of this, you make a long list. We do this with the med students every year. We make a pretty long list. But it kind of comes down to there's a handful of things that you could look at. Start at number 2 for a second because we'll come back to number 1. But the population is getting older. That drives up healthcare costs. Incomes are getting higher in the U.S. If you take a 1950, 1960 to the present view, when the country gets richer, we have more money to spend on stuff. Some of that stuff is going to be healthcare. So we sort of allocate that way. That drives up healthcare costs over time. Insurance helps to drive up healthcare costs. A lot of people are covered, especially if you take a longer historical view, getting more people covered will drive up healthcare costs. I don't have to pay for those MRI scans, so I get more of them. That's sort of just a basic driver. Health insurance will drive it. Other things going on, medical malpractice, certainly kind of a disaster in the U.S. at the current time. The medical malpractice system really needs some changes and probably drives some healthcare cost increases. Waste, fraud, and abuse, for-profit insurance plans, things like that you think we could save if we were just more efficient. All those things definitely drivers of cost growth. Sadly, though, all those things not the big driver of healthcare cost growth. We could fix all those things. We don't actually want to fix aging of the population, really, but we could fix other things, and they would save us some money. But we don't necessarily even if we did that, that would not change the U.S. cost growth. The big deal is utilization. Annoyingly, we keep coming up with great things to do for patients. We come up with MRI scans and pharmaceutical products and new surgeries, lots of things that are actually often good for us, but are frightfully expensive. And if you look at why the U.S. spends more year after year, and if you look at why we spend more than other countries, the big deal is that we have all this extra stuff that we've been coming up with and that we keep doing and that we have to keep paying for. And that's really the challenge of dealing with cost growth. So here, we'll write it in capital letters. That'll make it easier to notice. There you go. Expanding utilization is bigger. The challenge, of course, with expanding utilization is that some of this is efficient. Efficient being a complex economic jargony term for worth it, right? We get some benefits for the spending, and those benefits are big enough to make it worth our spending the money on it. But a bunch of it is inefficient. And we know this from various amounts of studies. The US healthcare system spends loads of stuff on things that don't actually make us healthier. Kind of an interesting side debate. They might make us happy. And there's some debates then about whether the healthcare system should be paying for stuff that makes us happy even if it doesn't make us healthy. We actually allow people to buy whatever car they want even if it makes them happy but doesn't get the groceries faster than a cheap car. We allow that. In the healthcare system, though, we have in the healthcare system allowed people to buy stuff that makes them happy even if it doesn't make them healthy. But as the budget gets tighter, we're going to have to sort of confront what efficiency looks like. Are we only willing to pay for stuff that actually makes us healthy, or are we going to be willing to let people buy whatever they want, even if it's kind of inefficient in the sense that it doesn't make people healthier? We got some efficient things and some inefficient things. Challenge number one is we don't always know what's what. Very hard for us to figure this out. Sometimes the same technology is really good for one patient, really inefficient for another patient, but we use it for everybody, and we don't always know the difference. Sometimes it takes us years to figure out that something that we're doing is a lousy idea, but we're not very good at figuring the whole thing out very fast, and so we make a lot of choices in the US. Our knee-jerk reaction is always spend more. Always do it. If you got something that you could use it. Without any breaks, we're always going to have a bunch of inefficient things going on in the system. And so we've got to get better at the first pass at figuring out what's efficient and what's not efficient. And we're not working that hard on that problem at the moment. I mean, people are trying. I don't mean to say that that's not going on. But the focus in Congress, kind of the focus of the healthcare system, is not necessarily on getting this stuff worked out. Why are there inefficient things going on? It's like a swirling cloud of things, right? And this, I'll wrap up on this because we could spend a lot of time talking about this too. There's no one reason that we're doing inefficient things. One of them, I guess it ended up in the middle, is population expectations. People like stuff. They like fancy stuff, right? So I grew up in Grand Rapids, Michigan, western side of Michigan, and I was back there a couple years ago. I was driving from Grand Rapids down to Kalamazoo, Michigan, to a little town, an hour south of Grand Rapids. And as I'm driving along, on the side of the road, there's a big billboard. It says, "There's nothing more serious." There's nothing more serious. Level 1 trauma, Bronson Hospital. And I go a little farther on down the road, and I see another sign, "Second chances happen here. Level 1 trauma, Borges Hospital," different hospital. And so I drive past these signs, and I get into town in Kalamazoo, and I ask my friends, I saw these two signs. They're kind of interesting to me for a reason I'll tell you about in just a second. What's going on? And they said, well, we got these two hospitals, and they compete like siblings. They are always trying to one-up each other. When one gets the open heart surgery, the other one gets the open heart surgery. One got the hospital or the helicopter, the other one gets the helicopter. We got two hospitals. Kalamazoo's got a couple 100,000 people in it, but they got two helicopters. They got two open heart surgery centers. They got two level 1 whatever. And now they have two level 1 trauma centers. Trauma center being a very fancy emergency department, so they both put in these things. But the interesting thing was that they took the trouble to advertise it, right? They spent their perfectly good money to put up a billboard on the side of the road so that I could find out that they had a level 1 trauma center. Why did they do this? Really interesting question. Usually you advertise things because you want to tell potential customers where they should come for the services. But if you need a level 1 trauma center, you don't need to know where the level 1 trauma center is. You're not asked about that. Somebody else is taking care of this. Why did they bother to spend their perfectly good money to put up a billboard to tell the world where there's a level 1 trauma center? Because people like to get stitches in the same room that there's a level 1 trauma center. People like to go have a well baby delivery in the same building that there's a level 1 trauma center in. People love this stuff. It expands their perception. The public community likes it. The idea that they have the fanciest thing in town makes people want to go there. We love technology. The population thinks more is better in general. If I go to the doctor doesn't do something for me, that's bad, right? If the doctor prescribes 15 things and a lot of specialist visits, that's good. And so part of what's going on with inefficient utilization is these kinds of ideas that the population has, that we all have, about what good healthcare is, and sometimes they're just misaligned with what's actually good for us and what may be good for Kalamazoo, Michigan, having spent now millions of dollars on 2 level 1 trauma centers for the same population that probably doesn't even need any at all. But they got to. What else is kind of floating around those population expectations? Well, there's capacity issues. We've got loads of scanners put in the US. We've got loads of MRI machines. We've got loads of ICU beds. We've got loads of other things. Maybe this is because the population wants it, but part of the reason the population wants it is because once you put these things in and doctors start to see them, they will get used, and the population will get used to having them. And so there's sort of a push that comes from having more of these things around that swirls around. It's driven by financial incentives. There are some high-tech things you can make a fortune on in this country, and that leads to more capacity sometimes, which leads to more utilization, which then swirls around. So we've got a bunch of things that are going on that are very interesting that have led us to the point where we have gotten used to having lots of expensive stuff, fancy stuff, that we think is sometimes good for us, and in fact sometimes really is, but often also isn't good for us, and we can't tell the difference, but we have no brakes in our system to really start to think about this very hard. And that's, I think, the big challenge for healthcare going forward. The US is going to struggle with this for 15 or 20 years. If we don't, we're going to go off the cliff. So we will have to deal with these kinds of challenges. The current health reforms do a lot of great things to get people coverage, but they don't really go here. And so one of the things that I think you ought to look for is health reform part 2, coming in a few years, probably coming in little tiny bits as we go forward, because we can get more people covered, but we're going to have to deal with this. And I think getting people covered is hard. We talked about the politics at the beginning. Very hard to thread the needle in a way that looks like we can get people covered. This is way harder. Giving people stuff to get them covered is giving them something. Fixing this looks like you go to the doctor and you say, I hurt my knee and I want an MRI scan, and somebody says you can't have it. So this is actually sort of taking things away or slowing things down, but trying to do that in a really smart way, and that's going to be politically necessary. The country can't pay for what we've been taking on as bills and responsibilities, but it's going to be very hard, and it's going to take a lot of work, and it's actually going to probably consume a number of years to try to get this right. So I think that's the big challenge. Grand opportunities to get people covered and sort of do more interesting things. So I'm going to stop. I managed to leave, 18, I thought I'd leave 25, but 18 minutes, not bad for questions. I'll take questions for a while, and I can actually stick around even a little bit after. I know you probably have more fun things to do than this, but I'll stick around for a little bit after. So how do I just do this however I want? Do you help me do this, or how do I do this?
I'll try to point out some people in the back who might not see their hands.
Well, I'll go. There's one person right here who's right. Yeah, you with the. I can't tell what's on your head. Yeah, guys in very dark suits with very stout looks. They're going to show up. Sorry. Okay. So the idea is, here's the question, and it's not totally subtle what the answer is. The question is, how are you going to enforce an individual mandate? So we're going to say in Washington, behave yourselves, get a bunch of health insurance, but then what if you don't? So what if you don't normally looks like, when you file your taxes, you have to staple your W-2 to the front. So one version of this is you're going to have to staple your proof of insurance to the front. And if you don't, then there's going to be a line in there, add X dollars to your taxes. So that's the main idea. There would be some sort of tax penalty, and it would be associated with tax filing because basically everybody has to do that already. And it would involve you providing some certification that you have it. Other people have thought about different ways to do it, but that's the one that's kind of gotten the most traction. Honestly, these bills don't always deal with that. They just say there will be one and there will be a penalty, but they don't say exactly. But it usually would have something to do with taxes. So over here? Okay. I don't know. Oh, sorry. That was the distorted financial incentive. So what I meant to do was have that reflect, what's an idea there? So FFS means fee for service. Fee for service means every time you do a service, you get paid a fee. So, if you go and you see a physician and the physician examines you for a little while and sends you for a lab test and sends you for a diagnostic image and then does a procedure later, each one of those things is a fee. And the financial incentives, when I sit in the econ department, what does that look like? The more stuff I can do, the more money I can make. Now, I don't mean to say that every doctor is motivated entirely by that. I think people are generally pretty altruistic. But when there's a chance for that, or when the system nudges you, the direction it nudges you is to do something extra. And so you get more scans and you get more things going on. Those are the kinds of incentives that lead people to buy more MRI scanners. Because why? Well, it might do some good for my patients. And to the extent I'm thinking about it, I can make a lot of money. Right? So these are the distorted financial incentives that we don't always kind of figure out right. I'm going to go right over here. Yeah.
Can you comment on the Cleveland Clinic model?
The Cleveland Clinic model. Yeah, so there are, so the question is, can I comment on the Cleveland Clinic model? It's probably too long a comment to make in detail, but I'll try to, maybe I can sum up and you tell me if I didn't get to what you're thinking about. So one of the kind of driving questions is whether we have organized, if you're thinking about cost growth and inefficiency and things like that, and you think about the underlying drivers, one thing I didn't put up there is organizational structures and the ways that we've built the system. We've built lots of different providers that are kind of all on their own bottoms, if you will. They're all sort of financially doing their own thing. So there's a specialist office, and there's an MRI center, and there's a lab, and there's some primary care doctors, there's a hospital. They're all trying to do their own thing. They're all trying to get their own business model to the extent that they're business people, and they all are business people at the end of the day, right? They're all trying to do their own business. But there isn't a lot of incentive in the structure to get people to work together and to say, well, we've got a patient coming in. How best do we use all these resources, right? A primary care doctor might say, well, I'm going to send all these different things around, and then there's nobody looking after the patient, and the incentives can get misaligned really quickly. So one of the interesting questions that floats around is, could we do other models? Could we do Cleveland Clinic is one, Mayo Clinic is one, Geisinger is another one, where there are large groups of people that have multiple different types of folks, and they have some different pieces of equipment. Is this what you're after? Yeah, so then we'll come to that too. Okay, perfect. So if you do that, can you get a better model? If you say, here's a patient with back pain, and here's $1,000 for your whole bunch of people, then you figure out who should be seeing that patient, rather than fee for service, kind of everybody seeing the patient a few times because that's their business model. Maybe we could get a better model. Some of these big clinics will do it. One of the other things that the clinics do is they use different payment systems, right? Your salary, if you work for the Cleveland Clinic, you're salaried. You don't actually make a lot of money if you do an extra procedure. Maybe you'd actually rather not do the procedure because then you can go home earlier, right? So you get a different sort of incentive, but it's not a utilization more incentive. It's hopefully a more balanced incentive. So building bigger systems, I think people are very interested in that. The history of the American healthcare system is that they have existed successfully in certain places, so there are definitely models that look like successful models, but there are also places where they have not successfully existed, or even places where they've started up and been driven out. And so it looks like it might be hard maybe to just take that model and plant it everywhere, but we got to do something, and it's certainly a successful thing that's been floating out there, so it's definitely an idea that people are talking about. I find it optimistic, I find it interesting, and hopeful that we could do more, but there are some challenges with doing it widely. Yeah, I'm going to go just right here. Oh, so there are phase-ins here. The individual mandate actually would only kick in 2013 in these different ones. So, well, okay, so two things going on. One of them, I think, legit. One of them, tricks. So almost all of this would phase in 2013 as specified. Now there are little bits of it. Some things would start to phase in earlier. One piece of that is that some of these regulations and some of the other machinery takes a little while to build. So I'll give them a little while. They shouldn't do it right away. If they did it too fast, I'd be mad because they would do it badly. But why as long as 2013? Well, the reason, honestly, that this is as long as 2013 is because the CBO is scoring a 10-year bill. So they have $850 billion over 10 years is the score. If they phased that in a year earlier, it would be almost $1 trillion, right? Because then they would have to pay the subsidies earlier, they would have to expand Medicaid earlier, they do all the other stuff, and that makes the bill too high. So there's a little bit of trickery because they have to hit that, because Obama said $900 billion. So they're hitting $900 billion by just saying, well, we'll do it later. Is that a good idea? I actually think that's a tricky and a very potentially problematic idea. I'm not a fan of that, and the reason is the instability that's created. Between now and 2013, we're going to have 2 cycles of elections. We're going to turn over the House twice. We're going to turn over 2/3 of the senators. We're going to have a presidential election. And at any point in there, somebody can undo this. So if you like this, now there are people who say that's great, there's lots of chances to fix it, but if you like this and it gets passed, then you don't create a constituency for it until 2013. There's nobody saying, I benefited from this, so don't change it until 2013. And that's 2 election cycles that you could change it. So if you're worried about keeping it, that's actually kind of a problem. You got to get enough consensus to survive a potential challenge in that time period. And so it's kind of a trick. Yeah, here.
How much of a role does personal responsibility play into the cost curve? Does incentivizing healthy behavior, how much of that?
Incentivizing health behaviors, personal behavior. So personal behavior is a big feature of this, and sometimes it's kind of hard to disentangle all the different parts of it, but obesity, for example, is driving a lot of what's going on in healthcare costs. Some pieces of obesity probably have something to do with individual behavior, some pieces probably don't. And so, how you start to disentangle what's personal behavior and what's, the other aspects of the American economy that drive some of this maybe, or other genetic change. I mean, all this kind of stuff is part of it. So it's hard to sometimes sort all that stuff out. But personal behavior is part of this. Smoking was a driver of rates and has kind of come down, and we could fix up some of that. If we fixed all of that stuff, I mean, if we don't fix obesity, we're going to spend billions more. U.S. is a $2.4 trillion healthcare system. So I'd guess I don't actually have the data off the top of my head, but I would guess if we fixed personal issues like weight, maybe if we pretended we could just fix that with some incentives, or smoking, which we're starting to fix, we could probably, I'm going to say, $10 billion a year, $20 billion a year, maybe $100 billion a year if you let obesity get really big out in the future. But it's not $2.4 trillion. It probably doesn't cut our costs in half. There's a long list of things that we should definitely do. And that's something we should definitely do. We should not create a system that incentivizes people to make lousy choices, and there are ways in which the American healthcare system incentivizes them to make lousy choices. We should fix our malpractice system. We should not waste money. We should get more electronic medical records because that would save us money. All great things to do. At the end of the day, not going to fix our cost problem, right? We got to do them, but we're going up for other reasons too. I did the front a lot, so I'm going to go in the back, right there. You, yeah, waving at me. You're the one, yeah. Okay. Good. I'm checking my watch, not because I'm trying to get out of here, but because partly that's a long answer, right? There's a lot to talk about there. And so I'll repeat the question, but, and then we'll try to figure out what to do with it. The question is, the US has private sector insurance companies, some of them for profit. I'm going to paraphrase your question. I hope that I don't blow it. Private sector, for-profit, sometimes insurance companies. Many other countries don't. If you look at, most other countries don't. I think there's only a couple that would probably look like us. If you look at rankings that have come out of, for example, the World Health Organization lately, the US does not rank as high as some of those other countries that don't have this. And so how do we think about then this sort of set of issues? So the US, so one of the issues is the rankings themselves, right? So some of those World Health Organization rankings can get, I get in big trouble if I started standing up here trying to defend all the parts to them. There's some artificialness to them. There's some extent to which those rankings themselves recognize the existence of a not-for-profit healthcare system as part of the reason that they're ranked higher. All right, so there's some debate about whether the US, where it would fall if you did other types of rankings on other types of outcomes. There are some outcomes where the US comes out above other countries, and there are some where it comes out below. But the World Health Organization rankings tend to emphasize like efficiency across, or equity across different groups of the population. And the US doesn't have a lot of that, but they don't emphasize as much, say, specific outcomes for some types of conditions. So the US might look better or worse. So I'm not sure, for starters, that I'd want to start that discussion with just those rankings. You want to start it with a more complex thing. But the broader question about how you do or how a system with private structure and private incentives can achieve what we want it to achieve, I think is a very deep and interesting question, something that I spend a lot of time thinking about, and you all probably spend time thinking about it too. One of the fundamental sort of facts about private insurance companies, surprise, surprise, is that they're private insurance companies. They are businesses, right? And one of the things that private insurance companies have discovered is that the best way for them to be successful businesses is probably not to take all the people in the country who want to buy insurance coverage from them. They do better if you don't take the sicker people. They do better if they can carefully decide who they're going to get. Now, I don't know that they all try to do that. Many private insurance companies are public-spirited, at least to some extent, and they will try to take a broad range of people. There are regulations that preclude them from sometimes really just driving it home and kicking somebody out. But at the end of the day, there is a structure of business that says, we're not necessarily about providing broad-based coverage to the entire country. And so that's a limitation. If you want to build a healthcare system that looks equitable, that looks like everybody's got fair access to it, and you want to do that around private insurance companies, you start out with a big challenge because they don't necessarily want to achieve a social goal of everybody having coverage. Now, can you do it with private insurance companies? It's not impossible to do it with private insurance companies. There are some examples in Europe. Switzerland, for example, has a lot of private insurance companies and very heavy-handed government regulation that sort of gets them partly there. They've got some other things going for them too. So you can do it, but it's harder. On the other hand, you create a government-provided insurance system. Some of these other countries have done that. That creates some good outcomes sometimes. It creates some equity across different groups of the population. But you can also get yourself in kind of funny situations with that too. Governments sometimes cut spending when you don't think it should be cut, and other things happen like that. So, I think this tension between there's like a big continuum, right? You want a private sector system, you want a government-based system. No system in the world is at either end. The US is probably farthest toward the private sector of any system around. And what we're doing is we're kind of sliding back and forth because what we see is the more government we get involved, the more we might be able to achieve, or we hope maybe we could achieve, some of these goals about getting broad access available to lots of people. But as we do that, every time you slide down, you maybe erode a little choice. Maybe you erode what looks like a nimble opportunity to be efficient in the marketplace to you. They haven't always achieved that, but maybe we hope that they could. So there's always this sort of push and pull back and forth, and we're talking about whether we move a little more toward the government side. Interesting debate. I mean, I'm sorry, that's a really long answer to maybe a shorter question. Oh, we're basically out of time. So I'm going to take one more question, and then I'm going to volunteer to stick around a little while because I got a little time to stick around. Right there. Yeah, good point. The U.S. wins the race in every metric in terms of highest cost per person per GDP. And one of the reasons for that is our utilization, and one of the reasons for our utilization is the kind of differences in the insurance system. It's not the only reason for our differences in utilization, but it is a difference. So what can you do if you're a single payer system, if you're Britain and you want to keep the cost down? Britain, all the money comes in as taxes to the government decides how to use it. If the government doesn't want to buy a new hospital, the government doesn't buy a new hospital. If the government doesn't want to put an MRI scanner in, the government doesn't put an MRI scanner in. So they have very different availability of services, and they can dictate a little bit more what types of doctors they have and where they go, so they can be, to their view, as efficient as possible with their dollars. And when you think about it that way, not everybody agrees with that, but if you think about it that way, what you can do is you can deliver reasonable health care to a lot of people for a lot less money than we deliver it here. When you don't let it go through a single payer, when you let everybody have a lot of freedom of choice, right? You choose your insurance company, that insurance company chooses which doctors to work with, hospital administrators, total free choice for where to set up a hospital, what to offer in that hospital. When everybody sets up in a much more free market system, then you get nobody exercising control about how much equipment we have, and you get what the US has, which is loads of equipment. Now, arguably, that has responded to our interest, right? We're buying that at some level because we want that. Maybe you say we're buying too much because we're insured for that, and that's another thing. But we're buying that stuff. And so what you get there as an example is two totally different ways of providing healthcare, organizing the system. When you get more of a government system, you get more control over utilization and what's out there. We have less control, we spend a lot more, and now we've got ourselves in this debate. Because, to characterize a little and slip past some of the details that you'll probably call me on, which is fine, maybe what we bought is a lot of stuff that we'd like but doesn't actually do anything for us. Maybe Britain is better at finding the stuff that actually really does something that makes people tangibly healthier, but they underbuy things that people would like. There are people there that say, I want this, and I think it'll work, but the government says it's not going to work, so they don't buy it. We buy all that stuff, and we probably waste stuff. Maybe they underprovide it, and that's the big difference, right? So stop with that. I'll stick around and answer more questions. Thank you.
For more, please visit us at stanford.edu.